clinicians, the academics from all the parts of the world and throughout our region. My name is Dr. Maher Sarraf, and I am a senior consultant in the field of obstetrics and gynecology and reproductive health, as well as co-founder and chairman of Baby Code Stem Cell Facility. Before I hand over to my eminent guests in this webinar, I would like to give you a brief history of Baby Code and how we have reached this monumental point of discussing our work with leaders in the field spanning across 2 continents. Baby Code Jordan started as an affiliate of the New England Cord Blood Bank based in Massachusetts in the US, to offer cord blood stem cell banking in Jordan in 2005. This soon evolved into an aspiration of setting our own stem cell and tissue bank in order to serve the health sector of our country and the region around us. We established the state-of-the-art Baby Code Stem Cell Facility in 2014, which was a fully operational cord blood bank and tissue bank, cell bank by 2016 with multiple ISO accreditations. A lot of hard work was put into achieving the American accreditation of blood banks, AABB, in 2018, which was its first accreditation in the Middle East. We added dental pulp stem cell cryopreservation to our service offering during that same year. By the end of 2018, we embarked in testicular tissue cryopreservation, to be followed 18 months later with ovarian tissue cryopreservation in April 2020, right at the heart of the COVID pandemic. We are currently working on placental tissue stem cells and adipose lipoaspiration to add to our portfolio, as well as the registration of our tissue bank with the US FDA. Our facility was built with state-of-the-art systems in place from its unique architecture, which has now become a familiar structure in the Jordanian society. Its latest technology and security deployed for the safety of the cells that we store and the lives that we hope to help in the future. Although we have become regional leaders in the field of cord blood and tissue banking, we are very proud of our new venture of the fertility preservation program, which bridges a crucial area of future reproductive health. It has 2 main established arms. First, testicular tissue cryopreservation for pre-pubertal boys and ovarian tissue cryopreservation for female aged 1 to 40. We have so far achieved validation of our testicular tissue preservation in collaboration with the University of Pittsburgh Medical Center, UPMC, in the US. We had our CEO and lab director visit the UPMC Research Laboratory and learn established protocols validated by UPMC to implement at Baby Code. Sample preserved tissue have been sent for histological and viability testing, and our process has been validated. We as Baby Code are continuously involved in a lot of exciting work that is currently taking place here in Jordan in this new field, and it is around the world and of course in the US, where we have our expert panel here to discuss with us today. Before I ask my colleague, Dr. Abdulatif Abu Khadra, to introduce our esteemed guests, please allow me to say a few words in Arabic to our audience. زملائي الأعزاء، انطلاقا من ريادة بنك الأنسجة بيبي كود لإدخال خدمة تجميد المبايض والخصيات وإعادتها إلى الجسم البالغ بعد الانتهاء من علاجه من الأمراض التي أخذ بسببها الأدوية الكيماوية والأشعة، وكون أننا بهذه الريادة نحمل مسؤولية الترجمة الدقيقة لهذه الخدمة الطبية الأحدث في القرن 21، أجد أنه من واجبنا الوصول إلى اصطلاحات الأدق في تسمية هذه الخدمة، أن نطلب منكم المساهمة في ذلك. وقد ارتأينا أن نقدم بعض الاقتراحات، وهي صون الخصوبة، حفظ الخصوبة، حماية الخصوبة، ديمومة الخصوبة إلى آخره. أرجو من حضراتكم إرسال اختياركم أو أي اقتراح جديد ترونه مناسبا على إيميل بيبيكود info@babycodejordan.com. والآن أطلب من الدكتور عبد اللطيف أبو خضرة تقديم ضيوفنا الأفاضل من الولايات المتحدة.
Thank you, Dr. Sarraf. Our first speaker is Dr. Kyle Orwig. Dr. Orwig is the director of UPMC Center of Reproduction and Transplantation. He's the director of Fertility Preservation Program in the University of Pittsburgh School of Medicine. Kyle, please.
So I should share my screen.
Yeah. You can stop, Kyle.
Okay, just a second. So, I cannot see.
Just a minute there.
Oh, here we go.
Great. Yeah. Now you can see, yeah.
Okay, just 1 second, please. Okay. Can you see this?
Yeah.
Okay, everybody can see the full screen and hear me okay?
Yes.
We can see the slide and we can hear you quite well. Please proceed.
Okay. All right. Well, first of all, thank you very much for inviting me to join this webinar with you. We've had a long-standing relationship with Dr. Abu Khadra and look forward to seeing where this collaboration leads us all in the future. Well, we're all here because we understand that medical treatments for some diseases can cause permanent infertility. We know that chemotherapy and radiation treatments for cancer can cause infertility, and also other conditions like bone marrow transplant for benign diseases such as beta thalassemia and others. And so for that reason, patients should be advised about the impacts of their treatments on future fertility and that there are options to preserve fertility. And as we all know, adult men and women have the options to cryopreserve eggs, or cryopreserve embryos, or cryopreserve
for especially junior people. And so for those of you that have career problems with COVID, reach out to your supporters or reach out to one of the senior leaders in this session. There are resources for you. And also, it may well be that the pandemic is forcing you to reconsider your career choices. Now is a good time to explore that. So don't be bashful about exploring these things. Now, there have been times when we would all come together, like this, for example, here at Woods Hole, and you can see Professor Orwig is way back here. It is probably unlikely that we will be hugging each other with the same closeness that we had. And you know that we have held wonderful meetings in Amman and elsewhere in collaboration with the Hashemite University, University of Jordan, and other clinics. And inshallah, maybe we'll be able to do this again, either face-to-face or virtually. All of these slides will be available, by the way. Now, Kyle gave you an extraordinary overview of what's possible today. In 10 years from now, it may be possible to take stem cells and drive them into sperm or eggs and make viable human embryos. And I just want to spend a moment on a collaborative study that was spearheaded by Charles Easley, where he could directly differentiate human pluripotent stem cells into haploid spermatogenic cells. Chaz has been able to now take these and drive them into further stages of spermatogenesis, inject them into unfertilized non-human primate oocytes, and generate blastocysts that are not generated by parthenogenesis, that indeed do have paternal proteins that are expressed in the embryos. And so this project is moving forward. I also would like to speak for a moment about aspects of the testis that aren't just the spermatogonial cells, because the epididymis is among the least understood organs in our body. I mentioned to my wife that the epididymis was the least well understood organ in a man's body, and she pointed out that actually the brain is less well understood in a man. In fact, maybe they have challenges finding it. But the epididymis is an enormously long organ, and if a sperm were the size of a man, it would be as if that man were walking from New York to San Francisco within about a week to get from one side of the epididymis to the other. It's extraordinary. It's about 3 times the length of a human. And in stallions, the epididymis is probably about 80 meters. It's an amazing organ, and we don't understand it. We've shown that there are changes in the centrioles that occur in the epididymis, and I don't want to go into a lot of details on this, but there is another field on whether nightmares can be inherited, whether epigenetic memories can be inherited. And these have been studied in Tutus, refugees, in refugees from Palestine and many other places. And it appears as if there are small RNAs that are transferred via the epididymis into the sperm. And this is in a non-Mendelian way. This is epigenetic inheritance of your adverse experiences, and it may well be that it's transferred for multiple generations. Now, this leads to notions about perhaps being able to avoid the transfer of genes or RNAs that set us up for anxiety and depression. But it's important to remember the health of the offspring is controlled not only epigenetically in the egg, but also in the sperm, and the epididymis plays a crucial role in this. Let me just end by spending a moment or two talking about aging. And here you can see a patient who has sperm here that look like little tadpoles, and later they've metamorphosed into frogs, and the doctor is saying, I take it you haven't had sex for a while. There are still issues about whether advanced paternal age has adverse effects. And here in a paper, they are looking at the rates of schizophrenia and autism in children fathered by men of advanced paternal age. So it may not be only that advanced maternal age represents a danger to the offspring, but there may also be dangers for mood disorder, schizophrenia, and autism spectrum disorders on the basis of the age of the male. Now, how could this be? One idea is that during male meiosis, you'll remember these cells are still undergoing cell division. So the spermatogonial stem cells are much older, have gone through many more cell divisions in a man's testis when he is 50 years old versus when he was 25. And there may be some neurotransmitter-related molecules that are overexpressed in spermatogonial stem cells that outcompete the others in the sperm of older men. And if you remember the Bible with Abraham and Ishmael, you know, he was a very old man, and then we got our messiahs from this. So I don't want to push the biblical interpretations too far, but there may be problems with advanced paternal aging that we don't quite understand. So I'm going to end this by saying that this is Donald Rumsfeld, who talks about how there are known knowns, and there are things we know. There are unknown knowns, that is things that we know that we don't know, but there are also unknown unknowns. And there's a lot going on in the scrotum that we don't know about. And things going on in the scrotum may very well lead to challenges of epigenetic inheritance in refugees, challenges of autism and schizophrenia. You know, they say that the guy thinks with his testes, and I don't want to push that too far. I'll get into trouble. But let me just end by saying this is indeed a family affair. This is my son, Daniel, on the day my daughter, Madeline, was born. And we love Jordan. We love all of you. Inshallah, we will be back together sometime soon. Thank you.
Thank you, Jerry.
Find on the internet, because there are many charlatans that are promising treatments for everything, and they're not following the correct procedures that you and Baby Court are following. So be very careful if you find something unusual on the internet. You're at grave risk.
Great. Thank you very much, sir.
Thank you.
Any further questions to Jerry?
I'll be around.
Okay, great. Now, I'll start my short talk. Actually, I'd like to thank you, Kyle and Jerry. Actually, it's very difficult to give a presentation after you guys, but I'll just do my best. Now, I'll be reviewing the incidence of pediatric cancers, cure rates, our current status in Jordan regarding its impact on the fertility index in the affected group, the young boys having cancer in their pubertal age. Now, the incidence varies from one country to another. In the USA, there is around 189 cases per million population. In Europe, 150. And in the sub-Saharan region, it's around 100 cases per million population. Basically, this changes might be attributed to the accuracy of diagnosis or screening. For the age group from 1 to 14, the most common cancers are leukemia, ALL, lymphomas, and brain tumors. The cure rate across the spectrum of all the pediatric cancers is around 80 to 85%, but the cure rate might go up till 90, 95% in certain conditions. With such a high cure rate, due to effective chemotherapy and radiotherapy, the majority of these young boys will survive the cancer, but due to the toxic effects of the chemotherapeutic agents on the spermatogenesis, they will become sterile. I'd like to share our results in Jordan. I would like to refer to a study that we ran in the Farah Hospital with Dr. Zaid Kilani, the late Dr. Zaid Kilani, and about non-obstructive azoospermia, the sperm retrieval in non-obstructive azoospermia, and it was coupled with simultaneous ICSI if we find sperms. Now, in the period from 2006 to 2016, we had 1,561 cycles, and this is by any means is a big study. The positive sperm retrieval rate across the scale was 51%. We had a positive fertilization in 90% of the cases, and the pregnancy rate was 24.5. Now, we'll go to the second style. I analyzed the results in preparation of this webinar for the patient who had received chemotherapy or radiotherapy in their pubertal age, and it result in being azoospermic, and when they got married, they come for us seeking to help them. And in the analysis of the results, the total cases were 54%. They are around 3.4% of the total number. The majority of the cases were actually ALL, lymphomas, brain tumors, and testicular tumors. The sperm retrieval rate in this group was 15, and it accounted to 31%. Positive fertilization was 93%, and the positive pregnancy was 3%. So Concluding our results, we had to go into a very detailed surgical procedure, which is not actually available in all centers, and we could only help 30% of this group of patients. 70%, really, we could do nothing about their condition. As in Jordan, in the Arab and the Islamic world, sperm donation is forbidden, not by religious beliefs only, but by the land of the law as well, by the law of the land. So we are faced with a very challenging situation in a community which strongly believe that the offspring and the children is the normal outcome of marriage. And it's the pillar even of any marriage. And infertility, unfortunately, is considered as a social stigma. Here I quote a verses from the Quran al-Kareem, and it says, Bismillah ar-Rahman ar-Rahim, Al-Mal wal-Banun zinat al-Hayat al-Dunya. Sadaq Allah al-Azim. And its translation in English is, wealth and children are the adornment of the worldly life. Now, reviewing all these factors, what are the solutions? The solutions is simple, and there are actually one solution which is valid, and this is in the post-pubertal men. If they have a cancer, cryopreservation should be done. Astonishingly, here and in other parts of the world, maybe this would be missed because of the hurry, because of the impact of the patient having a cancer, going into a denial phase, or it's just overlooked. And this is a big orientation campaign, taking in consideration that we should orient the health providers that deal in the oncology and pediatric oncology, especially if the patient has sperms and ejaculate, he should have the freezing. But for the prepubertal males, there are no solutions, nothing to be done. And here I would refer to the extensive presentation by Kyle in the beginning of the webinar, and I think that there is very strong data that we have some very encouraging and positive results. Hopefully, in the future, human trials will carry a further success, and it will be a very, very helpful tool in these young group of patients that we hope to help. I'm very pleased to announce that we in Jordan have the know-how and the ability to freeze testicular tissue, thanks to Dr. Shatton in the first place, who introduced me to Dr. Orwig. Dr. Orwig and his colleagues in Pittsburgh shared all the valuable information and protocols of tissue freezing. They authenticated our results. They had one of our team members visit their facility and take a first-hand look on the procedures. And they included us in their worldwide centers that is collaborating in this pioneer study. We hope that the success of this study will carry a future hope to help cancer patients in testicular preservation, in the fertility preservation, and to put our country on the map of stem cell research. Here I conclude my talk, and we have around a couple of minutes if you like to add anything, and hopefully we could come up with some endpoints that we could share with our audience. Thank you very much.
Learn from you, and maybe also share our experiences with similar patients.
Great. Gary, would you like to have an endpoint?
Yes, let me just say that some have mentioned that when God was setting up the world, she did not bless Jordan with a lot of resources like oil, but she gave you great brains and great hands and great expertise. And I see Aman as the magnet for intellectualism and for medicine. And I know so many people from around the Middle East and indeed around the world come to Aman for the very best of medical treatments. Ironically, it probably is easier to come to Jordan now than it is to come to Pittsburgh. And so, I think the blessings that you had, Aman, which truly was the city of brotherly love, the original Philadelphia, will continue, inshallah, for many generations to come. God bless you all.
Please, one question about freezing testicular biopsy. Do we need to validate the frozen sample every few years, or we just wait for the time where we need it for the surgery?
Yeah, the expectation is that you would maintain the tissue cryopreserved until you're ready to use it for surgery. There are some centers around the world, mostly for ovarian tissue, who do set a small piece of tissue aside to thaw it out before surgery and test the quality of the tissue. But most do not do that. Just simply thaw the tissue and then use it. That would be the expectation. Also, because the tissue is small in size, it's best to preserve the most of the tissue for the patient's future use.
Yeah, thank you.
Well, Kyle, as a minor modification, in the original protocol, the pediatric surgeon is going for a wedge resection that would take out quarter of one testis. Now, is it possible? We have the facility of microsurgical techniques, basically on the very, very wide experience we have in microtessy. And we could harvest a good amount of tissue without the wedge resection. And I think it's doable. Or do you have any objection on performing a microtessy, which would reduce the risk of bleeding, and actually it's more, let's say, a precise kind of surgery?
No, microtessy would be fine. It's a little bit more invasive, but I agree with you. With microtessy, it's easier to control bleeding and things like that. And I think the quality of tissue that you would get out would be fine. When you remove tissues, in my opinion, it will be best to remove an intact piece of tissue rather than individual seminiferous tubules, because if you dissect the tissue into individual tubules, I believe it will be difficult to do testicular tissue grafting. I think you need an intact.
Can I have a question?
So as long as you can get a good intact piece of tissue, then I think it will be fine by whatever method that you use.
Excuse me, Dr. Musharraf Abdullah from Lebanon like to be connected to her because he has a question. Can we do that?
Yes.
If it's okay with the panel.
No. Okay, please.
Yeah. Maher?
Michelle.
Hey, good evening. It's a very interesting webinar. I want to ask.
Is this connected?
Yeah, I'm sorry, we lost him.
Yeah?
Yes. Yes.
Michelle, we don't hear you. ما بيقدروا تجربوا ثاني مرة؟
Okay. I think we have came to the end of this webinar. Dr. Shatton, Dr. Ulrich, we really appreciate your help, your presence, your support. Both of you are a big asset to us, and we hope that we would carry on with our project and we share the success in future days to come. I think our colleague from Lebanon is back. I hope that the connection is good. We have just 1 minute and then we have to go out.
Sheikh, go
Yes.
ahead.
Yes, just a question for Jerry. How old is too old for the male?
Oh, Jesus. I mean, our president is very prolific in many, many ways. Yeah, you know the answer better than I do. It's
That includes me and Maher.
well, we both have aging testes. What can I say? I think it's better for many reasons to have your children when you are younger.
Yeah, absolutely. I agree.
Okay. I
Thank
am
you.
so sorry for the explosion in Lebanon.
Yes, unfortunately.
Terrible.
Thank you.
Be well.
Thank you all. Thank you.
Thank you.
Okay, sir. Here we adjourn, and we hope that we will meet not virtually, but very soon we could meet all in Amman. And again, on the behalf of all our audiences or audience attending this webinar, we'd like to express our deep gratitude and appreciation to your work and support. Thank you very much.
Thank you very much, Gerald.
Bye-bye.